So I can see you're all busily joining the room, and we'll get started in a couple of moments. Hey, welcome. Welcome to the last of our Patient Partnership Week events. We've had a fabulous week where we have been championing the patient voice. So I feel it's really apt that we're ending the week on championing patient voices in healthcare campaigns, and even more apt that we are the day after the launch of the 10-year health plan for the NHS, or the health plan in general. I want to say thank you to our sponsors before we get going, who without them we wouldn't have been able to organise and run this event. And we've had hundreds of people join us this week. So the webinar will be recorded. We find that quite often people love to go back and see it, and we see the watching of it, the numbers are quite high afterwards. So Emma will get this up on our website within kind of the next 24 hours, but by Monday. Please use the chat, say hello to each other. It's really nice for us to be able to see who's in the room. Because sometimes it feels really strange just talking into a screen. So do busily get busy in the chat box saying hello to each other. Closed captions are enabled for those of you who want to use it, and there is a Q&A button, but we did ask in advance for questions and for outcomes. So I hope that we framed the webinar to meet those outcomes and those questions that we've had, but you may have a few more as it's going on. So great. Hello, everybody who's joined there. Hello, Health Watch. Lovely to see you here with us again today. And so I'm Rachel. I'm going to introduce, the panel are going to introduce themselves in a few moments, but I just really want to set the scene for why we're here and what we're doing. So, like I said, it couldn't be more timely how we move simply from listening to patients to genuinely partnering with them, both in the design and delivery of services, but in their individual care. We have a Prime Minister yesterday who talked about the government being determined to put power back in the hands of people and professionals to make the best choices about their own lives, treatments and care. So we're at a pivotal moment in healthcare. You know, we've heard our Secretary of State talk a lot about power to the patient, and this commitment to putting power in patients' hands make our conversation today even more necessary. We know there has been some progress in recognizing the importance of patient voices, but too often we're still seeing that tokenistic consultation rather than true partnership. So real partnership means involving people with lived experience from the very beginning, not just asking for their input when we've already designed something, but co-creating the solutions together from the ground up. And whilst important, this isn't just about being inclusive. We all recognize that that's absolutely vital. It's recognizing that patients and communities and patient groups hold expertise that we simply cannot access any other way. So today's speakers will share how this partnership will work in practice, from Aurora and her work in community connection that builds trust with underrepresented communities, to John's experience at Sickle Cell Society, transforming individual stories into change, and to Rachel's and the core model that embeds authentic co-production throughout campaign development. So we will hear some real life stories here today. But the first thing I want to do is actually to open with a poll to understand more your interest in championing patient voice. So I'm going to give you a minute to answer this. Brilliant. So what is the most important element for effective patient-centered healthcare campaigns? Just give it a few more seconds. So fantastic. So co-creating is the winner there, which is fantastic. Interesting, the accessible languages hasn't received any scores, but I suppose if we're co-creating, we're actually learning from patients what they need. And then using real life stories. So we have 80%, 81% really talking about what I hope we're going to help discuss today. So I'm going to close down that poll and I'm going to stop talking and I'm going to hand over to Aurora. Aurora, thank you so much for finding time to come and talk to us today. Tell us about you.
Yeah, thank you so much. So good morning, everyone. Obviously, my name is Aurora Todisco, and I'm here today as a patient advocate and community connector. You may have seen me in other health and care spaces because I am someone who have lived experience of long-term condition, and I have also cared for family member. So I've seen the health system working or not working from both sides. And I'm deeply committed to involving patient and the public in the health and care. It's partially part of my job and partially obviously it's my life. This is often called patient and public involvement and engagement, PPIE for short. And but to me, it's not just a term or a process. It's about making sure the patient voice are part of every decision, not at the last minute addition, but from the very, very beginning. So why this is mattering to me so much is because real people experience can help create a better services. There are data and report out there. These are very, very important, but they don't tell the full story. The patient bring their real life experience that there are no report or clinical data can fully capture. So they explain what it's like to live with a health condition every day, and they can spot gaps the professional may miss. And they may help to make messages more clearer, service fairer, and care more human. So in my work, I connect with people from many different backgrounds and from different community, and these include people that are always left out. We have people from ethnic minority background, disabled people, neurodivergent individual, and people with language barrier, and also people they don't have greater trust towards the system. So in my role, I listen, I try to build partnership with them, and I want to make sure their voice reach the right places. And sometimes this is meaning helping people to translate NHS messages into community language. And I'm not speaking about word, I'm speaking about the tone and the meaning of the message. And sometimes it's meaning helping services to understand, to change. So people are feeling more safe and the environment is more welcoming. And, building trust take time. But I think when it's done right, a patient can become equal partner. They don't just tell their own story, they shape policy, they help campaign development and service improvement. So this is what co-production really means. It means working together as equal, sharing power and creating something better. And it's not just the right things to do, I think. It's leading to better services, strong trust and effective care. So thank you so much for creating this space today to talk about this. And I'm really pleased to be on the panel. If I want just to give you a little feedback about the poll that I saw today, for me it's about building recognition because patient voices add so much. And when we when we train people, when we pay people fairly for their contribution, you encourage the most honest and diverse participation. Thank you.
Brilliant. Aurora, no, thank you so much for being with us. We couldn't do this conversation this morning without your voice in the room. I'm going to hand over to John. I think thank you as well for coming.
Thank you very much, Rachel, and good morning to everybody who's on the call. It's very much a pleasure to be part of Patient Partnership Week, particularly because of the NHS plan that Rachel mentioned was launched yesterday. So I'm John James. I am the Chief Officer of the Sickle Cell Society UK, which is a national charity, been around a long time. And what we do is advocate and support people who live with sickle cell. Now, as Rachel gave you a little intro about why individual stories is important in achieving systemic change, and let me tell you as an audience that sickle cell is on all indices the biggest genetic blood condition in this country, but the least funded, and where patients have genuinely poor experiences, particularly in accident and emergency. So individual stories has been key to what we have done as a charity. So in all of our advocacy arrangements, whether that's through parliamentary roundtables, through NHS England, integrated care boards, NHS trusts, whatever the infrastructure is, we want to ensure patient stories are part of that conversation. Real stories, real impact, and hopefully lead into meaningful change. So it's important that it's almost, there's an old saying, there's a stick of rock, and it's like the sort of patient voice and patient stories has to be all the way through that rock, not just at the top or the bottom, all the way through. So I'm just using that illustration to say that the stories of patients, particularly in a bigger story of health inequalities, is really, really important. And I just want to draw out some lessons that we've learned from that process of patient voice, and Aurora touched on those. So, and this is particularly important in terms of working with the NHS, whether that's an ICB, a trust, or NHS England. And this co-creation is really important as a principle. There's a lot of experience of where things are imposed and we're going to do it this way. That isn't helpful. That isn't co-creation. It's not about imposing things or saying we've come with a plan and this is what we want patients to tell us. That's not going to work. So that's one thing that we've learned. I think another thing that we've learned is that when you work with the system, if I can call it that rather than calling individual parts of it, the system needs to be reliable for patients and trustworthy. So reliability and trustworthiness of the system is key. Another lesson that we've learned. And a third lesson that we've learned is not to be silenced. The system can sometimes try to silence you. Oh, that's too difficult to hear. We don't want to hear that. You know, can you tell us something a bit more positive? Well, actually, if people's experience are not positive or negative, then don't try to silence that because it might, you know, affect reputation or of the organization. So those are some of the things that we have learned in that process of using stories for systemic change. And then the final thing to say is that if it is successful, and it has in part been successful for the Sickle Cell Society, it's resulted in national campaigns funded, because we don't have the money to fund it, funded by NHS England, and also new pilot services that can improve the experience and care for people, particularly in accident and emergency. So those are real examples of that systemic change that drove really from voices of individual patients, individual families, in a bigger picture about health inequalities for this group of patients. So I hope those insights are helpful. I am on the panel with Aurora and others, and happy to contribute in the conversation later this morning. So thank you, Rachel, and thank everybody for listening to those points. Thank you.
John, thank you so much. I've just put a copy of that great report by the NHS Race Observatory into the chat box that you were talking about there. And I think, and I'm going to come to Rachel now, but I think that bit about trust, because I think if you look at the findings in that report and some of the quotes, I was crying in pain. They just shut the curtain, you know. And we had a patient on earlier this week on one of our webinars with sickle cell who really talked about that experience. And if they're the experiences you're having, you don't have trust. And if we don't have trust, we're not going to work in partnership. So, but we're going to come back to a lot of questions on trust and people feel the too difficult to hear box that we often get put into. I find like I'm in that box quite often. So, Rachel, can I hand over to you, and thank you.
Of course. Thank you, Rachel. So first of all, I would just like to also echo my appreciation for being invited to join this discussion. My name is Rachel Pay. I work in the private sector. I work for a company called Weber Shandwick. We are a public relations consultancy. I'm based here in the UK, and I do lead the healthcare offer across the EMEA region. And just a little bit of background, because I don't know that our organization will be known to all of you, but we do work very closely in the healthcare sector with clients, both large multinationals, mid-sized specialty pharma companies, and also smaller healthcare companies. And we work across all areas of health, from pharma to diagnostics, medtech, and consumer health. And a great deal of the work we do in partnership with our clients is really focusing on awareness campaigns, helping people to really better understand the signs and symptoms of illness, and also supporting them in their health journey. A big focus on education, healthy living campaigns, prevention campaigns, and so forth. And I think that is why the patient voice and working hand in hand with patient advocacy partners like the Patient Association is so critical to us. We made a commitment. We did a big kind of a reflection. I guess it was all, it started, if I'm really honest, on the back of the pandemic. And we really did some soul searching as an organization into what we could do to better improve the work that we were producing on behalf of the clients that we represent. And that's really when I found Rachel, and I found another really important person who has been on this journey with us, Dr. Tammy Boyce at UCL, working in health equity. And we did a big focus on what is the role as health communicators to really help address some of these very prevalent inequalities and inequities that are existing in healthcare. And that's when we came together with the Patient Association, and we did a very deep listening exercise. And I think that's where this all starts, really, is in listening. It's less talking and more listening. And we worked on a strategic framework to improve the outputs of the programs and the campaigns that we are delivering, as I say, in conjunction with our clients. And I do feel really passionate that, you know, we all have a responsibility across all sectors, and it's not just for the advocacy organizations and indeed the public health organizations, the NHS. Private sector also has a very big part to play in this. So fast forward, we launched only in March of this year what has been celebrated as a very pragmatic model, which is open to everyone to apply, which really puts equity and some of our underserved communities at the heart of healthcare. And that is called CORE. It stands for community, offer, respect, and ease. And if I could just ask if we could perhaps try and cue up a very short video which brings this to life.
Thanks, Rachel. Hopefully this will work, because I think Holly has sorted the gremlin in Zoom.
Ooh. Just a little time lag, I think. Great, I can see the cursor.
When we communicate vital health information, too often we only speak to a select few, leaving many communities struggling without the information they need to live their healthiest lives. It's time for change. Co-created with the Patients Association and Health Equity Advisors. The core model is a strategic framework for developing healthcare communications. It brings deep insight into the barriers facing overlooked groups, helping us reach each community in a way that resonates, providing an offer that is tangible and helpful, leaving behind stereotypes and treating people with respect, and making sure messages can be understood with ease. Because if we want people to value their health enough to take action, they must feel valued themselves.
Thank you. So since we launched CORE, we have been actively working with our clients to apply this model to our everyday work. And we're really pleased to actually have a model that is also holding us accountable to really do more to bring some of our underserved communities to the core of what is often not necessarily called out in the original brief that we may be responding to. So, you know, my belief is that no two patients are the same. The manifestation of diseases are different. The experiences navigating healthcare and the system are very different. And it's our job as healthcare communicators, as consultancy, as advisors, to work harder to reflect this through all areas of our work. And that's really what our partnership with the Patients Association and some of our health equity advisors is really all about. So thank you. And just to say, it's very difficult to do core justice in a panel discussion like this, but if there is anyone who wants to follow up post this morning's webinar, I know Rachel and I would be delighted to have an opportunity to dig into some of the more practical application as to how we bring this to life.
Brilliant, thank you. Every time I see that video, it gives me a shiver, because it's like, it's not difficult to know that we need to do this, but we make it too difficult. And I think for me, that partnership has to start at the beginning, which is why I was really happy to get involved in this piece of work around health equity, because by the time people are in the system, they've lost power already. So if we can get power before then. So time for some questions, guys. Thank you so much for all of that. So I think I want to ask a question to each of you, and I think it's that one simple thing, because what I want to do in this is try and break it down to make it more simple as to how we can do it, because we're going to take the learnings from this and make sure that we amplify what we heard today. Emma's in the background, Holly is in the background there. We have to say thank you to Holly, actually, because just before we did this, we couldn't get the sound to go. So in the middle of trying to keep this webinar running, she also managed to get the sound working and stay calm. Well, from where I'm sitting, she looks like she was calm. But Emma's in the background as well, and Emma is writing up some of this work so that we can really push it out afterwards. So what I want to ask from each of you is, what is the one simple thing that organizations can get wrong, and what should they do? And try and do it in one thing. And I'm going to come to you, Aurora, first of all.
Yeah, thank you so much for your question, Rachel. So I touched base a little bit on this topic while I was doing the introduction. The most common mistake, in my opinion, is bringing the patient in too late. So when decisions are already made, and this feel like a tick box exercise and limit the real input that we can do. So what they should do instead is to involve patient from the start before decisions are made, and to make it a real partnership where lived experience of is shaping the process. And I can give you an example from my work. So in one particular campaign, I've been asked to invite some people to review some material, and all the printed material were already there. So they use, obviously they spent some money. There were hundreds of paper already laying on the table, and our feedback couldn't be used. So now I always ask to the team to co-create things from day one, because it's saving time and also building trust with the community. Because if I bring people in your space, you need to give them voice and importance. Thank you.
Thank you very much. And John.
Yeah, well, I'm going to be slightly controversial, Rachel, in the sense that I think, so for the audience, people who live with sickle cell look like me, black, brown people, mixed race people, Asian people. So sickle cell affects mainly people who look like me, but there are white individuals who have sickle. And why I'm painting that picture is, again, the system, and that can be individual trusts, it can be ICBs, are very good at using, just to illustrate, you know, the sort of demographics of their regions, pictures of people on their annual report and on their publications. But sometimes those people don't see what effective services for them actually mean. And so the point that I'm making here, Rachel, is actions speak louder than words. We want to see the system working in the way that Aurora and the core principles that Rachel Pay identified, resulting in action and change. And that's the key point, because it's back to your earlier point about trust and reliability. It isn't a one-off kind of transactional arrangement. It's a continuous process, and therefore actions speak louder than words. And what we want to see from our interactions with the system and those stories is that there's change, and that change is improving health outcomes and health experience for people, whatever long-term condition or other condition they might have.
Thank you. John, I'm going to ask you a supplementary question to that, because it's something that's been on my head. And of course, it was in the long-term health plan vision yesterday. Obviously, we need an implementation plan. So, you know, that's your very comment. We have a plan yesterday, but now we need to see the change that the plan is talking about. How does patient, I often, well, I do have a concern about how we measure patient experience, because I think sometimes we measure it from a system. You know, was your GP appointment on time? Did you get the letter on time? They're not really important into what matters to you. Did you manage to live your life well as a result of it? Did it enable you to do different things? From your perspective, how should we be measuring patient experience?
Well, I would like to see some metrics that have been derived by patients. So if we go back to the earlier conversation, Rachel, there's sometimes an element, as the system does, that we will create these metrics to measure how we're doing. And in some of those cases, there's been no patient voice in any of that whatsoever. And I want to illustrate that with a real example. So some young people with sickle cell, if you have sickle cell, you have regular crisis, and you have to go into accident and emergency very regularly if if you're not managing well. So it's a high consumer of accident and emergency, and a lot of young people, male and female, who go in regularly are deemed drug seekers. Oh, you're back here because you want another shot of morphine or ketamine or whatever. So the pain relief isn't paracetamol, it's controlled drugs. And here we have, to the point that Rachel Pay made, stereotyping of patients, and there is no metric internally. The only metric about that experience in A&E is how long they've how long they've been in A&E when they've been triaged. So we need more nuanced, sophisticated metrics, in my view, that have the fingerprints of patients on them and families, as opposed to those who are working in performance in the system. Hope that answers your question.
No, it does. And I think some of the testimony in that report that I put in, and we heard it in a piece of work we did around social determinants of health. Rachel, hearing all of that, I don't have to say Rachel Pay because now I know you. But John is doing a very good job doing Rachel Pay, because I get really confused when you and Rachel are in a room. People go,
Yeah.
Rachel's going to do this. And I'm like, did I promise to do that? So, Rachel, I think for me, you've heard a lot there around, you know, bringing patients in at the beginning, that trust and reliability, that silence, you know, the experiences that some patients, sickle cell patients, have is just horrendous. What makes healthcare campaigns successful and reaching communities? Because I think if we can start getting the communities feeling valued, they'll have power when they're in that in that interaction within a crisis, a sickle cell crisis, and they're, you know, having comments like that meant to them.
Absolutely. I mean, I think that there are so many learnings and ways in which we can shift the way that things have historically been done. And, you know, the importance, sorry, Carol, I'm just going off, hope you can't hear that, but the importance of this early engagement is, I think, really important, but it's also about the meaningful involvement. So it's being on that journey. And the insights piece, I think, is just so critical, because when you do more listening, and listening with the full breadth of the patient audience that is impacted by a condition, that is when you unlock something which becomes just such a powerful platform in which to develop a meaningful program, support program, awareness, engagement, whatever it may be, that people get behind and relate to. So I really feel as though, you know, this move from the more tokenistic to true collaboration, co-creation, full journey from the listening and the insight mining through to the creative, through to the activation. That is where we get the best results, and that is where we see the impact of our work. You're muted, Rachel.
Yeah. I'm going to come to Aurora because you've got your hand up, and then Rachel, I think there's another video you want to show. Is there?
Yeah, I was going to come to that in
Okay, no, that's fine.
That's
fine.
great. Yeah, love to.
Okay, Aurora. What...
Yeah, I just want to add up on the table a tangible example of from one work that I did. So in a vaccine campaign, we noticed that older Black and South Asian residents, they were trusting faith leader more than leaflet that were going on around COVID, etc. So the team worked with faith leader to share messages during prayer time, and obviously also using some sort of communication channel that are usually not used by the NHS, such as WhatsApp, etc. And there was a successful campaign to listen to community first, because they co-design with people of this community future messages that have been shared, and these avoid one-size-fits-all messaging, and they use some trusted messenger, because the most important things is to capture local leaders or peer advocate to push for change. So it's not about the language, it's about the tone, the culture, the value, and all the access. Thanks.
I think you're completely right. And I often use the story of the vaccine as a real example of working with communities in, you know, how community leaders worked with each other and actually identifying, you know, doing with people rather than, you know, sitting at the top and dictating down as to, you know, And I see it now with some other messages that are coming out. I'm often listening to the radio going, why are you on the radio telling me this? Get out into the communities, go talk to people, understand the barriers, understand where the fear and the trust is, and what you need to break that down.
From the vaccine hesitancy, now we shifted our work to prevention, like cancer prevention campaign, etc., but with the same sort of model, and it's working really well.
Brilliant. So, Rachel, did you want to share that video now?
Yeah,
or
so
later?
let me just give a little context, because I just want to caveat this is a piece of work that was not specific to the core model, because we had actually started this before we created with Rachel and the association and Tammy Boyce, the framework. But we worked very closely with a patient association in Ireland called CRE. They're dedicated to heart health, and what they really wanted to understand with us is how we could raise awareness of heart attacks and the symptoms of heart attacks in women. We know that cardiovascular disease is the #1 killer of women, and there is a lot of poor understanding around that. So by listening to women who had either been impacted by a heart attack, or the families of women who sadly had lost a loved one to heart attack, we found a really powerful insight. And it was really through, as I say, listening, we found this insight. And the insight was that many women, their first port of call for the symptoms that they are experiencing, which are very different to the symptoms of a heart attack in a male patient, are often the first port of call for information is a Google search or another search engine platform, and in some cases, tragically, that is also the last port of call. So this campaign, I believe, is just a really powerful example of co-creation from the very beginning, art direction, input, everything from the storytelling, authentic, trusted voices, and what that can look like when you do it well.
When a heart attack hits, every minute could mean the difference between life and death. Still, women wait on average 37 minutes longer than men before calling for help. The disturbing reason? They're unsure what's happening to them. The symptoms of a heart attack differ between men and women, yet only men's symptoms are known. Known to the public, known to healthcare systems, known to women themselves. Before dying from a heart attack, women's search histories can be filled with their symptoms. Now, these search words have become the key to stopping preventable deaths. In collaboration with families throughout Ireland who'd lost loved ones, we brought these search histories to life. Through social films, Google ads and search terms, media relations,
launched a campaign to raise awareness of the symptoms of
Christmas, and like all women, I thought it's just stress.
And talent and event partnerships.
Campaign aimed at raising awareness of the signs and symptoms of heart attack in women.
It's bad because I couldn't tell you what the symptoms are that are different to men.
People across Ireland had an emotional response to the campaign. But first, we conducted a national study to validate that female symptoms were unknown. And last, we did the study again to track progress. Turning a dark search history into a brighter future.
Brilliant. Thank you for sharing that, Rachel. It's really moving. And I think that's a huge bit around healthcare campaigns. I suppose John and Aurora, I'm going to come to both of you now, and we have a lot. We have a lot of our wonderful Health Watch colleagues on this call today. They're watching, they're in the chat box, and I first of all want to pay huge respect to them because they have done a massive job in raising the voice of patients. And as a patient association, you know, we've worked really closely with a lot of them, and in particular Health Watch England. The government have talked about patient voice in the long-term plan, but in the same handwriting, we found out this week that Health Watch is going to close. In the plan, and in some of the conversations I've been having this week, I fear that we don't understand the need to advocate for patients sometimes, that we don't. So every healthcare campaign needs to, and patient charities need to advocate for patients who don't have power. So how can we change the culture? Because John, before everyone came on the call, you and I were having a little bit of a culture, because all the healthcare communications in the world aren't going to work if we end up going in feeling that we have power because of work of core, or the charge sheets, or the videos that we have there, or the work that I do, or the wonderful work that Health Watch does, the work you're doing, Aurora, the work you're doing, John, that they walk in and the culture is different. So how do we get this genuine listening? I'm unmuting you, John.
If Aurora wants to go first, or do you want me to go first, Aurora? Entirely up to
Same,
you.
yeah, that's all right, yeah.
Okay, well, I guess, Rachel, two perspectives. The deficit of patient voice in the 10-year plan and the abolition of Health Watch is something that does concern me. So as a charity, we every day, Monday to Friday, we are advocating on the behalf of patients. So the notion that a patient going direct to a hospital or a GP practice will be heard is mistaken. Some will be heard, you know, the sharp elbow people and people, you know, but a lot will not be heard. And let me just give you an example, because this was on my email at 4:30 yesterday. A young person has died. Parents have written to the hospital in 2023. They have had an acknowledgement, but no reply. And they said, look, we just don't know what to do. And back to Rachel's point, they're not listening. They are absolutely not listening. So that is an illustration of some of the basic human care is missing. And one of the ways to address that, I think, is about addressing those things that we are potentially normalizing, because I think just hold on for a second. I'm just going to finish this point, but just think 20 years ago, or even, you know, 10, if somebody was on a chair in A&E, it would make the front page of the media.
Yeah.
Today, people are on chairs in accident emergency for a long period of time. It seems perfectly normal. So I think there is something about addressing some of those basics and getting back to caring for people in a way that shows compassion and kindness, to be perfectly frank. And I think we're missing that. So one of the ways of doing that is about, you know, the training and education of healthcare staff. The science and the clinical skills are great, but actually you need compassion, you need kindness, and you need empathy. And I'm just saying that if you contrast the fact that many patients don't get that basic kindness and empathy now, we're in danger of normalizing poor care, and that means problems for patients. Sorry for that long-winded.
No, I think
but I
that's
think it's really important.
I think it's really, really important. And our National Free Fund Helpline hear those calls every day. And we hear about injustice. And Aurora, I'm going to come to you about injustice in the system. And I raised injustice in the system with the Secretary of State this week, because I think we need to think about how we're going to do that listening to patients now. And we don't know, we have an idea what's coming post Health Watch, because there was something about the office of the patient in the 10-year plan and the patient experience person, but I need to read more about that before we can talk more about it. But I think injustice is a huge thing. And Rachel, I'm going to come to ask you about how, so if you hear John, all the healthcare campaigns in the world aren't going to work. How can we use healthcare campaigns to make sure that, you know, that we do have kindness, empathy? And I think that picks up on some of the questions in the chat, which are talking about how do we train people? People don't get trained in shared decision making as well as possible. But John, I want to, you said, you know, a few years ago that it would be people sitting in corridors would be discussed. And I find and talk to journalists, and it's very, very hard to get stories about health. You know, stories that when I joined the Patient Association that would have been front page are now, you know, and even we've seen it this week, there hasn't been that much talk about a long-term plan. But I found this the other day, and actually it was somebody in government who mentioned it to me, and I thought, my God, we still haven't. So Bevan, founder of the NHS, recognised the importance of addressing complaints to ensure system effectiveness and improve patient experience and care. And he actually said, he famously stated that a dropped bedpan in his Welsh constituency would reverberate around the Palace of Westminster, emphasizing the need for transparency, lesson learning, and continuous improvement. So he knew that understanding concerns and listening to patients was crucial for the NHS's success. So hopefully we can get back to that. So injustice, NHS not listening to patient feedback. How do we change that?
So number one, I want to thank the person that in the Q&A raised the issue about Health Watch. So many of us feel some uncertainty. I can tell you my 9-to-5 job is for an organization that is managing a number of local health watches in Northeast London. So I'm deeply worried for the staff, etc. I do work in HR and finance in the corporate team of this organization. So with this announcement that Health Watch may be closing, a lot of people are rightly asking what happened to patient voices now, because our role was to leverage you know, the injustice that we are talking about. So Health Watch has been a trusted place for patient and carer to speak up, share their view, and know that someone was listening. And losing this will create a real gap, especially for local voices and for those who don't always feel confident on navigating the big system. So what we can do, I guess, is what we should be asking us, is keep speaking up, you know, through patient participation group, local volunteer organization, a national network, such as the Patient Association, campaigning together to make sure, obviously, whatever replaces Health Watch must still a patient voice fronted and centered, and then push for real co-production. Is not just a consultation, but obviously patient and carer should be helping to shape the decision and not just react to them. And finally, we need to organizations that take more responsibility for creating safer space for patient and carer to speak up, with or without Health Watch. Obviously, we are ready to, you know, reevaluate ourselves and move towards a new system. So our voices should not disappear just because the structure is changing, but it means that we'll need to work even harder to protect the peer principle of listening, the principle of inclusion and fairness. And, we must remind to those empowered that it's not about us without us, is a strong statement. The system may be broken, unequal, system will be always having some sort of exclusion criteria, and there are some institutional injustice, etc. These are all things related to the injustice that you asked me to comment on.
Yeah.
So I'm sure a system that claimed to be fair or person-centered, but practice, silences and exclude and harm people, should be challenges all the time. Thank you.
Yeah. So somebody in the chat and the questions is also talking about the fact that the National Speak Up Guardian is proposed to be closed too. We don't know the detail yet, and we don't know the understanding. So it's very hard to discuss. But my concern would be, and I think you'd all agree here, if we talk about partnership between with patients, it has to be with frontline staff. But frontline staff have to feel safe to speak up. So I will be looking very closely, because if we don't feel safe to speak up, if there isn't a psychology of care for staff, then we won't be able to get the right outcomes for patients. So, sorry, Rachel, we're coming to you there. So all the healthcare campaigns in the world, how can we use healthcare campaigns to really change the power balance within the healthcare system?
Well, I think that is a $1 million question, is it
I
not?
know, sorry about that.
But one
and
that I
you
would
probably weren't expecting it, but I think it's quite important to try and address it.
Yeah, absolutely. And I think it's an enormous challenge, right? But again, I feel like I am the representative from private sector, and as I mentioned, the consultancy that I work for, really, a large focus of our efforts is working with the healthcare industry. And I do think that I'm really fascinated by something that was just said. I saw it in the chat around listening and listening workshops. And as you were all talking, I was thinking about how, I often get pulled into workshops, but they're more about projection, right? They're more about how do we communicate, and how do you train us to be effective spokespeople, and how do we build advocacy, and I would love to just think about a way as a senior person within healthcare communications to be doing more around listening and what that means. And that is a real gift, right? And it's something, I always think that one of the things that best equip me in the role I do is to be the mother of 3 teenage girls, and I always am struggling with their lack of listening. So I think that there is something very, very powerful in that, and I would love to be able to consider a way in how we could, private sector, really do more to take that forward. So yes, sorry, that doesn't really answer.
It does. No, I think it does. I think you've absolutely answered it. I think the thing is that we do look at communication, and unfortunately within the system, sometimes it's because we send you a letter, we think we've communicated.
Yeah.
But you can't get back to that letter, the amount of people. So I think it's recognizing that listening is part of communication.
Absolutely.
The most important part. Okay, well, I'm sorry, but we are coming to the end of this webinar, and it could go on for hours longer. I have so much more I want to ask you, but I think I'm going to come to each of you now to think about, and I think we've covered support systems. We've covered that tokenistic practice that we see happening. We're talking about genuinely listening. For someone walking away from this, and let's go forward 2 years. Long-term health plan sitting here beside me on my desk because I'm trying to read through it. What will it look like? What difference do we want to see around patient voice and patient power? Aurora, I'm going to come to
Sorry,
you.
can you repeat the question, Rachel?
2 years down the line, 5 years down the line, what do we want to see? How do we want to see a system working with patients and giving them power? What will it look like?
So I'm thinking about the true patient voice work, and that is not just about storytelling or feedback. It's about redesigning the system together to work better. So in this 2 year, potentially we should be focusing on this. Obviously, you need to work better for the people that it serves, and this is the only way to do it, is do it together. So this is my closing thoughts, let's say.
Our closing is together.
Yeah.
John. You're on mute, John.
About that, I forgot to take the mute button off. For me, in 2 years' time, the difference will be ordinary people, whatever condition that they have, speaking well of their experience of the health service, whether they are accessing a GP, a physiotherapist, a dietitian, a hospital, speaking well about their experience. And that because I think if they're speaking well about their experience, it goes to Rachel's point about listening, and the things we talked about. So this is Rachel Power. Things we talked about are empathy, kindness. So listening, empathy. So if that happens in 2 years' time, progress has been made, and they can measure that. We talked about measurement. They can measure that. It's about 24-25% satisfaction rate at the moment. So it needs to treble that to make any meaningful difference.
And Rachel.
I 100%. Before John spoke, I jotted down celebrate the success. And I think again, as a communicator from a healthcare perspective, I really feel very passionate about that, because I do think that there are, and there will be, on the back of this, hopefully some really amazing pilots and programs that we can wrap our arms around and say, this is working, these are the results, and that will just fuel greater confidence and a sense of value and hope for the system.
Brilliant. Aurora.
Yeah, the recognition part and the celebration of what patient advocates are bringing to the table is very, very important. So I want to say that.
No. And I think it is, it's that culture, isn't it? To change that culture into listening at the highest. And if people are very interested in that, if people are interested in that, I did the webinar with the Chief Executive of NHS England the other day, and he talked hugely about transparency and listening and what he did in his Chief Executive roles at trusts. And I think he genuinely means that. Okay, we're going to have a last poll very quickly because we have 1 minute. I think we should say happy birthday. In the chat they're saying it's the NHS's birthday tomorrow. So I think we should say happy birthday, because we do love the NHS. We just wanted to listen to patients more, and that we realise that better together is the way we can do that. So question 2, what is the biggest, I think this is a different, I think we may have a problem. Okay, let's do this one. Yeah. Lack of genuine patient involvement. Okay, well, we are going to take this poll away with us because I want to make sure that we have some clear actions, and I want to bring in a lot of this into the patient experience issue within the 10-year health plan, and work with some of my other colleagues in the voluntary sector and patient advocacy groups and with patients. And Rachel, it'd be good to talk to you about this more. But that's really interesting. That the biggest one is that patient involvement. Yeah, starting with patients. Thank you all so much for joining us. It's been a pleasure to have you all with us. And Aurora, thank you, because I know you're traveling this week, and trying to find quiet places is quite difficult. Obviously, I know sometimes these webinars bring up a lot of issues for people, so our National Free Phone helpline is there. And the other thing, I want us to be able to know that as a patient association, we run lots of events to involve patients. So on our website, you can either sign up as a member, which is free, but there's a lot of focus groups, and through our weekly newsletter, we put out opportunities from a lot of different organizations to get involved, because we need that patient revolution, and we need to get involved in everything we possibly can do get involved in. Yes, the video will be available on demand. So John, Aurora, Rachel, thank you so much.